Welcome to Podcast UK.
Hi there, I'm Sanjay Majumder, and in this episode of Podcast UK, we shall be discussing the management of lymphedema. I have the very great pleasure of having in the studio Miss Malia Mughal, who used to be one of my trainees, but now is an established plastic surgery consultant at Guy's and St. Thomas's in London. That makes me feel both very proud and very old in equal measure. Malia is a microsurgeon with subspecialty interests in breast reconstruction, head and neck surgery, and of course, lymphedema surgery. Malia, welcome to Podblast UK.
Thank you very much for asking me to speak on your podcast. It's a real pleasure, and I'm very honored to be doing it.
Ms. Mughal, the honor and privilege is all ours on Podblast UK to have an expert like yourself. So to get the ball rolling, I wonder if we could ask you to give us a working definition of lymphedema and perhaps a bit on the pathophysiology, please.
It's a chronic progressive condition which is characterized by impaired lymphatic channels or impaired lymphatic drainage. And that then leads to this interstitial fluid accumulation, leading on to inflammation, goes on to fibrosis and adipose tissue deposition. And that's the sort of pathway that you kind of see as you see someone who develops lymphedema in how it progresses. I think it's really important to understand what the pathophysiology is if we are going to discuss treatment options. It is mainly due to lymphatic dysfunction, either congenital or acquired. And what we will see as surgeons here would mainly be acquired through iatrogenic causes, which is related to cancer treatment. A lot of patients that we see would be coming through either the skin or melanoma clinics where they've had groin dissections and all the lymph nodes in the groin have been removed, or we'll have our breast cancer patients who have axillary lymph node dissections, leading to disruption in the main channels that will take away your lymphatic fluid. And then radiation-induced lymphedema, which then makes it worse. It affects interstitial fluid, it affects fibrosis, and results in lymphatic damage.
That's great. Thank you very much. May I please ask, how big of a problem is lymphedema in the UK and globally even?
So in the UK, there's about 250,000 to 450,000 patients currently who are living with lymphedema. Majority of these patients are due to secondary lymphedema rather than primary, and majority of these would be because of iatrogenic causes, which is cancer-related or radiation-related. In addition to that, you have a lot of gynae oncology patients who will also turn up to your clinic with bilateral lymphedema. If you look at a group of breast cancer patients, anyone who's having an axillary node clearance is at risk of developing lymphedema in that arm by up to 35% in some institutions. Things have gotten a little bit better because now there's better understanding of the disease. There's better understanding of the condition. There is more understanding of anatomy as well. And breast surgeons are now targeting axillary lymph nodes rather than just going for a completion dissection. Similarly, with melanoma as well, because of the trials, there is less and less of full clearance that is being done. So there's been some improvement and evolution in terms of how cancer-related lymph node dissections are carried out, but that doesn't mean that it takes away the patients that are already in that pathway where this is a sequel of their cancer treatment. And then another thing that is very prevalent in the UK itself, or the Western world, as we would like to call it, is obesity-related lymphedema. And the pathophysiology of that is that you have excess adipose tissue, which leads to impairment of the superficial lymphatic channels, and then that leads on to accumulation of fluid. So it's kind of like it's like a catch-22, where one thing is just making the other thing worse. And that's something that's important for us because obesity is on a rise in the Western world. And it's also a difficult diagnosis because there are two conditions that can go hand in hand with each other, which is lymphedema and lipedema. And it's important for doctors who are dealing with lymphedema to be able to separate lipedema from true lymphedema. Currently, the NHS spends over £170 million per year on patients who are admitted for lymphedema-related cellulitis. Infections is one of the biggest reasons why lymphedema patients are admitted to hospital. If you're looking at developing countries, then there's mainly infection-related lymphedema, which is due to parasites. You may have heard about filariasis, and that is one of the main causes if we're looking at developing countries. And then also If we're talking about primary lymphedema, which is lymphedema due to congenital causes, that's also more common in the developing countries as compared to here. That is congenital or hereditary in terms of Milroy's disease, or precox, which is in less than 35-year-old patients, and it's called Major's disease, and it's more common in the adolescent or early adulthood age. And then you have lymphedema tarda, which presents after the age of 35 or 40.
That's very interesting, Malia. So, what are the current views on the management of lymphedema?
The most important thing to kind of understand about lymphedema is that it is a lifelong condition. It's not a disease with a cure. The treatment mainly is supportive. Even though we can make it better, we can never cure it. Supportive treatment, which can be non-surgical and surgical, and we talk about it as we go on, is to manage the symptoms and prevent progression, and also to prevent the associated complications of lymphedema.
That's really a nice, clear outline of the overarching principles of the management of lymphedema. But what does a surgeon do when they're first faced with a patient in clinic, or a trainee faced with a patient in the exam, for instance?
If you look at a patient who's presented to you with a swollen limb, so definitely history is important. If your history tells you the most probable cause of lymphedema, then cancer would be one of them. Radiation would be one of them. There's a couple of things that you need to get by just a general physical examination. If you're looking at patients who've got a obesity-related lymphedema, their body habitus will give you an idea of why they have a swollen limb. Looking at a normal limb and comparing it to the limb that is in question, looking at the skin, the color, and the changes that are associated with lymphedema are important. You can have discoloration secondary to venous insufficiency. You can have signs of chronic infection where patients have had cellulitis, which is a sequelae of lymphedema, or lymphangitis. So that's really important to see when you're just looking. The next stage is to feel, checking whether or not there is pitting. Because when you have excess fluid, you'll be able to press in and see if there's any pitting. These things are important because they then identify the class of lymphedema according to the Lymphology Society classification, which goes from stage 0 up to stage 3. Which is the worst type of lymphedema. So stage 0 is subclinical. You don't see any clinical signs. There may not even be a difference in the limb size, but your patient may mention to you that their limb feels heavy, or it gets a little bit heavier as they do daily activities. Stage 1, you will be able to get some pitting edema, and it's reversible in most cases by just elevation of the limb. So they'll say that, oh, well, I work in the garden or something, and I notice that my hand gets swollen, but then when I put it up, it feels better. Stage 2 is where the fibrosis starts to set in. That's where tissue starts to become harder because of the stasis of fluid in that area. And when you have stasis, it causes inflammation. Inflammation then leads on to fibrosis. And this is the non-pitting type of edema, and it doesn't resolve by elevation. And it doesn't resolve by stopping the activity patients may associate with their limb getting swollen. For example, if it's the lower limb, walking a certain distance may make their limb swollen. And then stage 3 is what we call severe lymphedema, and that is severe fibrosis with associated overlying skin changes, including skin thickening. It also goes hand in hand with fat hypertrophy in the area, and it also is associated with recurrent infections.
Thanks. That's a really clear outline of the clinical stages of lymphedema. But there's also another classification, isn't there?
The Campisi classification is the other classification, which I think is quite important just to mention, but it is more of a radiological classification, and it kind of discusses everything based on imaging findings.
So, what are the imaging options available, please?
Lymphoscintigraphy is the gold standard because it evaluates the lymphatic flow. In addition to that, an MRI. So I will always get an MRI of the limb that is affected because it gives you an idea of what the soft tissue component is versus the fluid component. And it kind of guides you into how you are going to provide treatment or what treatment options would be better suited to that patient. Another way of looking at the lymphatic channels is indocyanine green lymphangiography. And that is a dynamic assessment of the flow in the superficial lymphatics. So not the deeper lymphatics, it is more to look at the superficial lymphatics. So you use a dye and a fluoroscopy camera, and that allows us to look at whether or not there are any patent lymphatic channels within that limb, which later on we can utilize in terms of bypasses when we talk about surgical management. MRI lymphangiography provides an anatomical detail of where the fluid stasis is, and it's very useful in pre-op planning. Some people may say getting an ultrasound is good. I don't think getting an ultrasound is that necessary if your clinical examination confirms a diagnosis of lymphedema. What I do think is important is to get a duplex ultrasound to look at the venous integrity is equally important.
And what about the actual treatment of lymphedema?
Now, if we're talking about treating lymphedema, there's conservative management and then there's surgical management. The surgical management is then divided further on into physiological management, surgical management, and ablative procedures. And we'll talk about that, keeping in mind the classification that we discussed earlier. Now, in stage 0 lymphedema and stage 1, conservative management should help the patient in terms of managing their disease on a day-to-day basis. The recent NICE guidance that has come out last year in April, the first thing that is mentioned is early assessment and education of patients, and then conservative management is the mainstay of the treatment of lymphedema. First line treatment is complete decongestive therapy, and there's various modalities that formulate complete decongestive therapy, which we call CDT. And in this is included manual lymphatic drainage, which is a specialized massage technique, which allows the lymph to be pushed back up and into the venous system, so allow that extra fluid to be taken away. Then there is compression therapy, which is multi-layer bandaging, and that is then converted into long-term use of compression garments. Then there's exercise and physiotherapy, which is extremely important because that encourages lymphatic drainage. And most importantly is skin care, especially patients who've had radiotherapy. It's really important that they have appropriate moisturization, they're able to look after their hygiene and manage any kind of superficial infections, and giving them the education that if they do notice any infection or signs of redness, then they should get on antibiotics earlier rather than it developing into something more serious. There is some evidence about medical therapy, and historically diuretics were thought to be useful. It's not recommended now because it has been shown to be ineffective, and also it can worsen protein-rich fluid stasis. Moving on from that, we would go to surgical management. It's indicated in patients where conservative management is not useful or is not limiting the progression, or what we call refractory lymphedema. Or if you're having more than 2 infections or 2 hospital admissions because of cellulitis, resulting in severe functional impairment. Now, I mentioned earlier that surgical treatment is then divided into physiological procedures, where we are restoring the lymphatic drainage, or it's ablative procedures. And that's dependent on the stage of lymphedema. So we talked about conservative management being useful in stage 0 and 1. Now we're coming to where physiological procedures may be useful. And I always think that a classification is only useful in surgery when you can actually use it for how you would guide your surgical treatment. The most common thing that we use in terms of surgical management of lymphedema is a lymphaticovenous anastomosis. This is a surgical technique which involves supramicrosurgery because your lymphatic channels are less than 1 millimeter in size. They range from anywhere between 0.3 millimeters to 0.8 millimeters, and it involves bypassing the superficial lymphatic channels into veins. And the way this is done is by carrying out ICG lymphography of the limb that is involved. So ICG dye is injected into the terminal end of the limb, either the web spaces in the foot or the web spaces in the hand, and that will then identify through fluoroscopy the patent lymphatic channels. If there are patent lymphatic channels, then you are able to carry out this procedure. So it's best for early stage lymphedema with functioning lymphatic channels. And because the ICG lymphography gives us a dynamic view of how the lymphatic channels are working, it allows us to point out where we can do a bypass. The procedure itself is carried out under a local anesthetic. For each limb, you would do 3 or 4 of these bypasses to be able to give up to a 20 to 30% reduction in the limb size. Again, keep in mind when you're talking to your patients about any surgical procedures for lymphedema, you have to let them know that this is not a replacement for the compression or the conservative management. They still have to carry on being compliant with their manual lymphatic drainage, with their physiotherapy, with the compression. It's an adjunct to all of the above, and it allows them to have a better quality of life without their lymphedema progressing. I know there are some studies that say that patients can come out of compression. I'm still quite skeptical. The next step up, if you do not have any patent lymphatic channels, so a lymph node dissection has been carried out, you've now got lymphedema, which is stage 2 to 3, where fibrosis is already settled in the limb. In that case, you would do a transplantation of lymph nodes, and that's called a vascularized lymph node transfer. It's similar to what we do in terms of a free tissue transfer. The transplantation of lymph nodes is carried out from either the supraclavicular area, the inguinal area, or the omentum is a very good source of lymphatic tissue. It has amazing amount of lymphatic lakes in it and can be harvested with laparoscopic surgery. The only thing with using the omentum as your donor is that it does require a general surgeon. The most debilitating side effect of taking lymph nodes from another area is that you can potentially cause donor site lymphedema. And the most common site for getting donor site lymphedema is the groin. So it's not my most favorite part to harvest any lymph nodes from. However, if I'm doing a delayed Dieppe flap reconstruction, then the lymphatic channels that are available or the lymph nodes that are available in the circumflex iliac area are something that is readily there, and it prevents the patient from having another donor site. So that's quite useful, but I wouldn't do it as my first choice. The supraclavicular area is at least risk of donor site problems. Also, our neck has hundreds of lymph nodes, so taking some is not going to result in significant morbidity. The submental lymph nodes are also a very good donor site when you're doing a vascularized lymph node transfer. However, a lot of patients don't really like the donor site scar because it's quite visible. But if in terms of donor site morbidity, the supraclavicular and the submental is least associated with risk of donor site lymphedema. Another thing that some of the later studies are showing is releasing the vein or releasing scar tissue in the limb that has got lymphedema can also help with the venous flow, and that can also improve the limb volume. Long-term improvement in limb volume and infection rate is best with a vascularized lymph node transfer. And in some cases, we would also carry out a vascularized lymph node transfer and utilize a lymphaticovenous anastomosis as an adjunct. And that has shown better results if you compare it with either of those procedures done on their own. The complications, as I mentioned, donor site lymphedema, which you have to counsel the patient about. And a lot of patients will probably not choose to have it done because they worry about that. It's something that I use as my first line if I'm choosing a vascularized lymph node transfer. Because it's like a free flap, there is always a chance of the vascularized lymph node transfer not working because flap failure or vascularized lymph node transfer failure because you've got a clot within your recipient or donor vessels or the vascular supply is compromised. In that case, it becomes a necrotic piece of tissue, which then just has to be removed. There's another small procedure which now doesn't get done as often because it hasn't really shown the superiority that a vascularized lymph node transfer or a lymphaticovenous anastomosis has shown, but it would be important to just mention it, and that's a lymphatic graft interposition. So it's a lymphatico-lymphatic bypass, and that's where working patent lymphatic channels, which you can identify using, again, your indocyanine lymphography, can be used from an unaffected limb as a bridge to restore the lymphatic flow between channels in the affected limb. Again, it's rarely performed, and I don't really do it because asking a patient to give a donor from a limb that is not affected, the psychology of them having to deal with the fact that what if I get something in the limb that is the good limb, is quite difficult, and I find it difficult to justify that to patients. And it's only limited to really selected cases where you can see a bridge where you can put two lymphatics and put a graft between those lymphatics. Usually what happens is if you're doing a lymphography with the ICG, you'll see patent lymphatic channels, and then suddenly where the lymphedema gets worse, there's like this starburst appearance where everything starts to spread out. And it's normally at that junction that you want to do your lymphaticovenous bypass so that you can just just about at that junction, get your bypass done. It's very rare that you will find that that is the worst part and then there's another good lymphatic following on from that. So that also limits the use of this lymphatic bypass. And it has less predictable results than a lymphaticovenous anastomosis or a vascularized lymph node transfer. So these are the physiological procedures that we can use to improve lymphatic drainage.
May I ask you a couple of questions, please? The first is when you do a vascularized lymph node transfer, how do the lymphatics in the limb actually connect up to these lymph nodes?
So we're relying on this becoming the main drainage and then for some lymphangiogenesis.
Yeah, so essentially what you're seeing is by putting vascularized lymph nodes into the area, there's a stimulation of lymphatic vessels to grow into the lymph nodes and connect up. Is that correct?
Yes.
The next question really is about terminology. So the lymphovenous bypass and the lymphovenous anastomosis, are they essentially the same process but two different names?
Yes. Here we call it the lymphaticovenous anastomosis.
Great, thank you. So really both terms refer to lymphatic vessels being channeled into veins. Right. The next question I have was about node to venous shunt. I'm not quite sure what that is. I wonder if you can clarify that for me, please.
I personally have no experience of doing that. But again, it is very similar to the lymphatic bypass. You would find a vein and then attach it to a draining node and find a lymphatic coming out of the node. It's not widely used, and I think it's a very theoretical term, really.
And the final thing I wanted to ask really about the reconstructive options for lymphedema was the use of free tissue transfer separate from using the vascularized node transfer. Are you able to give us some more about that, please?
Actually, I'm glad that you pointed that out. So lymphedema is not just related to cancer itself only. Sometimes, and maybe you've come across this more than I have, Mr. Majumder, because you do lower limb trauma. Patients who have low limb trauma end up having skin grafts, disruption of all the lymphatics in that area. Same with the upper limb as well. Would have two areas which are fine, but then there's an area where there's disruption of the lymphatic channels. And that results in swelling distal to that area where there is disruption.
So if I understand what you're saying, Malia, you're speaking about a situation where there is an area of trauma, possibly circumferential, which creates an intervening area of poor lymphatic or disrupted lymphatic flow between two otherwise normal areas of lymphatic flow. Is that correct?
Yes. So what we can do is by introducing free tissue transfer, which comes with its own lymphatic channels, we can resurface that area to provide some continuity, release all the scarring, which also kind of helps with fluid not accumulating in the area distal to the injured lymphatics. You can form a bridge of healthy tissue which has its own lymphatic drainage to help. So yes, free tissue transfer as an adjunct to a vascularized lymph node transfer, and I've done that for a patient who's had a lower leg resurfacing with skin graft after a motorbike accident, using an ALT flap to revascularize that and put a vascularized lymph node transfer at the ankle to improve the size of their foot so that they can wear normal footwear again. So yes, thank you for reminding me about that.
No, thank you very much. That's really useful. Right. Can I now ask you a bit about preventative surgical management of lymphedema? And of course, we're now getting into territory of lympha and TILA. And for those of you who don't know, lympha, that's LYMPHA, is an acronym for lymphatic microsurgical preventative healing approach. And TLAR, that's TLAR, is targeted lymphatic axillary repair.
Yes. So preventative surgical management is something that has come up in the last sort of 10 years. I mean, it's been around for a while, but the data associated with it has been more robust in the last 10 years. So lympha, it was the traditional term that was used for what we now call immediate lymphatic reconstruction. It's basically doing a preventative lymphovenous bypass at the time of the clearance of nodes. So if a patient is having an axillary node clearance, and I'm going to mention this here again, more importantly, because NICE gave out guidelines last year Initially, this was offered to patients who are having groin clearances and axillary clearances, where a lymphatic channel will be identified using either blue dye or ICG lymphography, and it will be bypassed into a vein, which when you're doing a nodal dissection, you will come across many veins that the breast surgeons or the melanoma surgeons are clipping while they're doing their level 3 clearances. But the guidance that has come through from NICE, and I think it's important for everybody to know that they have not been able to show that there is no oncological risk in melanoma patients because of the spread of melanoma is slightly different. Therefore, it's not recommended anymore to provide immediate lymphatic reconstruction in patients who are having a groin dissection because of melanoma. But in breast cancer patients who are having an axillary node dissection and in gynae patients who are having an oncological nodal dissection because of their gynae pathology or breast pathology, we can use lympha or an immediate lymphatic reconstruction. The way it's done is by injecting dye into the upper arm, and that will identify the lymphatic channels that are draining the upper arm, and you can then bypass it into a vein that is in the area. Similar to if you inject into the lower limb and you can identify a vein in the groin. I tend to use blue dye in addition to ICG lymphography just because sometimes ICG is not readily available everywhere. And in this case, because I'm not looking for flow, I'm just wanting to identify the channels, blue dye works just as good as ICG. The anastomosis itself is the same way you would do any microvascular or supramicrosurgery anastomosis, so there's no difference in that. The important thing with doing an immediate lymphatic reconstruction is actually the recipient vein. The recipient vein needs to be long. It needs to have less pressure in it. So therefore, the reason you want a longer length of it is because that increases the number of valves that are in the vein. Because if you're going to bypass lymphatics into a vein, you want to be able to make sure that there's minimal backflow in that vein, because otherwise the pressure gradient doesn't work. So you're relying on movement and physiotherapy of the arm to push the lymph through, but you can't have too much blood coming backwards through the vein that is then going to push the lymph back into the channels. You want that lymph to be able to make its way up that venous channel.
So could I ask, in terms of lymphaticovenous anastomoses, are these end-to-side or are they end-to-end?
So from a technical point of view, there's various ways that you can do it. There's the traditional way of just intussusception, where various lymphatic channels are intussuscepted with a J stitch into the recipient vein. An end-to-end anastomosis of a good lymphatic channel into a decent recipient vein gives you the best results. And a lot of studies have now shown that it's better to do one good lymphaticovenous anastomosis than choosing for an intussuscepting. So it is an end-to-side if you get a good one. I tend to use an 11-0 or a 10-0 if I'm doing an end-to-end anastomosis, but I've also done quite a lot where you can use a 1 millimeter coupler, especially when you're doing it in the axilla. The lymphatic channels there are quite big, so you can get a 1 millimeter coupler on it. The other thing that I tend to do a lot is the end-to-side thing that you mentioned, is do it into an end-to-side. Again, it's more to do with the backflow and what kind of recipient vein there is. If it's a very big vein, you don't really want the blood just to be gushing back into your lymphatic channel, because then it's not worth it.
So you're really highlighting the very sensitive pressure gradients that you're dealing with, aren't you?
Yes, it's a low pressure system, the lymphatic system.
Is there any particular difference between the lympha and the tila, or are they essentially the same thing with slightly different acronyms?
No, it's just the new modern word is now repair or reconstruction rather than preventative.
But technically, it's the same thing. It's technically the same. It is a lymphaticovenous anastomosis, essentially. Is that right?
It's a lymphaticovenous anastomosis, and the reason why the nomenclature is different is the timing. So instead of doing it in an established lymphedema case, you're doing it before lymphedema.
Yes, I'm the one with the probing difficult questions. So please may I ask you about success rates?
So, as I said, if it was curing the condition, you can talk about success rate. It's more about how well it does for your patients in terms of their symptoms. The first thing that a patient mentions to me where I think that I can start counting success is they come to clinic at normally about 6 weeks or 7 weeks. They'll say, my limb doesn't feel heavy anymore. Is there at that time a size difference? No. As time goes on, you can start seeing the results. And again, if you do a vascularized lymph node transfer and an LVA as an adjunct, you have better results. Better results are counted not on just the reduction of the limb size itself, which because that's a long-term outcome, but also in terms of how well they're able to use their limb throughout the day. For example, if someone wants to cook in the evening and they're saying that, oh, after cooking, I just couldn't keep my arm down. It would just become so heavy. They'll say, oh, I can get through an evening of cooking or a day of gardening and I just don't feel like it's heavy. And sometimes they'll say, I just don't feel like I need to put my compression garment on. But obviously I want them to keep their compression garment on.
Yeah, I completely get that. But, well, are there any more objective studies that you can employ?
You can use bioimpedance studies. There are also various scanning machines that are now available, similar to what we have in gyms where they measure your body fat. You can measure fluid volume, and that's the earliest way of diagnosing when someone is getting lymphedema. So I think it's quite important that although it's not readily available everywhere, it is one of the gold standards of being able to assess early onset lymphedema because it can show you microfluid versus normal fat distribution, and that can then lead you to either start compression early in a patient who doesn't know they have lymphedema because they may have it subclinically, or stage 0 where the limb hasn't shown size differences. The other thing is objective measurements at the wrist, elbow, and upper arm, again at the ankle, mid-leg, and thigh. So objective measurements in the next year to 2 years following any kind of these procedures will show you that you're making an improvement in terms of reduction of limb size. What do I quote my patients in terms of what the success rates are in terms of limb reduction? I would say anywhere between 20 to 40% is the limb reduction, overall limb reduction size. But does it take away their lymphedema completely? No. For the immediate lymphatic reconstruction patients, I get them to be seen at 3 months, 6 months, and 1 year. And they have volumetric measurements using the LDEX machine, which gives us the fluid versus fat ratio. And it's also very useful, as I said, in picking up early subclinical lymphedema, because that allows me to start them on compression therapy earlier. Again, there's something I probably should have mentioned a little bit earlier. The lymphatic healing approach, or TLAR, or immediate lymphatic reconstruction, which we do for prevention of lymphedema, if the lymphedema risk is, say, 30% in a patient who's having axillary lymph node dissection, that risk is not completely reduced to 0 if they have a lymphatic reconstruction at the time of their clearance. That is only halved. So majority of studies have shown up to 10%, if being reduced from 30 to 40%. In my unit, we've reduced it to under 10%, but our previous institutional rate of lymphedema was 32%. It doesn't make it 0, which is why the monitoring is extremely important afterwards, because if you catch lymphedema early, going back to our basics of the treatment of lymphedema, we have to start them on conservative management early, and that will help them with the progression of the condition.
Malia, you've discussed before that lymphedema and lipedema are two separate conditions, albeit they can, coexist. And you've discussed, the different surgical techniques which can be employed for these two different conditions. But I wonder if you're able to give us a bit more clarity as to how one actually diagnoses one versus the other. So the lymphedema as opposed to the lipedema, please.
So pure lipedema, you will notice that the foot doesn't change size. So you can still pinch in the second web space, the skin. In pure lymphedema, there is global swelling all the way down. And you may have seen patients where they have this ringlet around the ankle, but then the leg is quite big. So that's more adipose tissue as compared to fluid accumulation. And the treatment would then, we're just about to come on to the, ablative procedures that are utilized in surgical management of lymphedema. And those patients are suitable more for the ablative procedures. And liposuction is the mainstay of treatment. Coming forward with the surgical procedures, which are now ablative procedures, these would include liposuction and then the Charles procedure. And these are the same for a patient who's coming in for lipedema, not the Charles procedure, but liposuction itself. So liposuction is carried out with a suction-assisted device under a general anesthetic. What's important to know is that when you do high volume liposuction in patients with lipedema or lymphedema to reduce the size of the limb, you have to keep an eye on their electrolytes because it causes a physiological fluid shift, and it's quite important that you keep an eye on that with regards to high volume liposuction. The other thing that's important is that it is one of the modalities which we would say address hypertrophy of the limb in the quickest way possible. So if you do liposuction, you have immediate reduction in the size of the limb, and therefore is associated with a higher degree of patient satisfaction. However, it does not improve the lymphatic function, even though there's a significant reduction as compared to the 20 to 40% that we can have with physiological procedures. There's 70 to 80% reduction in limb size by using liposuction. It does not improve the lymphatic function. It will only remove the excess tissue. Taking excess tissue means you get left with loose skin. Now, we have to be careful when we're excising the loose skin because lymphedema patients are still at high risk of getting infections. So they can be associated with an increased risk of wound healing problems. Doing suction-assisted liposuction is better for patients who have late-stage lymphedema and they've got fibrosis. However, it's better when the patient has good skin elasticity and no active infection. The procedure itself is standard like tumescent liposuction technique, which takes away the fibrotic fat. You would think that there would be disruption of the remaining lymphatic channels, but actually there is no evidence to show that there is disruption of remaining lymphatic channels, if there are any. Although it's difficult to see these in these fibrotic legs if you did do an ICG lymphography. They do, however, require lifelong compression therapy postoperatively to prevent reaccumulation. And you will see patients coming back and wanting to have more liposuction at 1 year, 2 years' time when their limb starts to get heavy again. The postoperative pathway is similar for both the lipedema patients and lymphedema patients. They get compression bandages and then, again, remeasured so that they have the correct compression garments given to them. Complications with this procedure, although, as I mentioned, are a bit higher than any of the other physiological procedures that we perform for lymphatic surgery, because you can have persistent postoperative seromas. Contour deformity, although is not really a main concern for many of these patients, they're just so happy to have the weight of the limb taken away. But if you had to be critical of your own surgical technique, you can end up with contour irregularities. And then, as I mentioned, they will end up with skin laxity, which you may have to address by excising some skin. But then you are also probably dealing with someone who may have delayed wound healing. And then for severe fibrotic limbs is the Charles procedure. Now, I know it's kind of explained as a very historical procedure, but I do think that it is used more than previously thought, because there is no other way of improving a severely fibrotic limb. You cannot get a liposuction cannula to suck out fat in a severely fibrotic limb. And the only surgical option in that case is radical debulking of that tissue. And it may have to be done in stages. So the concept of it is complete excision of the lymphadematous tissue down to the fascia, and then you can use a split thickness graft. Now, if it's being staged, you may have to take away all the lymphedema fibrosis and use a VAC, a negative pressure dressing, and then skin graft it later, or you can do it all in one go. It's a very, I wouldn't say morbid. It looks more morbid than it is, but it does require blood transfusion. There's a lot of big veins that, get disrupted, and there's just a lot of bleeding at the time. So it's important that you have the patient optimized to have a procedure like this. It's mainly indicated in patients who've got elephantiasis or filariasis, where there's severe fibrosis and severe ulceration of the limb, secondary to the parasitic infection. Or if you have a non-functional limb, which is cellulitic and has recurrent cellulitis. So it basically takes away the whole lymphadematous tissue, and then the skin grafting is done onto exposed fascia. And the outcomes, obviously, are a significant reduction in the limb volume, but associated with high morbidity, and is obviously cosmetically poor. But it may be the only option, and taking away the excess weight that they're carrying and taking away tissue that is going to become cellulitic or cause infections resulting in multiple hospital admissions is probably something that they would choose over not having the procedure and accept the morbidity that is associated with it. From a complication perspective, of course, you're creating wounds. You could have graft failures because it's hardly the best vascularized bed to use for skin grafts, and recurrent infections, although less, are still possible. So that's kind of it in terms of the ablative procedures, but then there's some emerging techniques, and there's always research, which is what makes our specialty exciting, that there's always something else coming up. And some of the latest developments in terms of lymphedema is stem cell therapy, just like any other subspecialty. Stem cell therapy and research into adipose-derived stem cells to regenerate the lymphatics is coming up, and then the growth factors. So the lymphatic system, similar to our vascular system, is all reliant on these growth factors like VEGF, VEGF-C, and it's just something that can give the potential to enhance lymphangiogenesis and can be used as an adjunct to the surgical procedures, for example, a vascularized lymph node transfer. And another thing that is now coming up is nanotechnology-based drug delivery. There are certain trials which are testing lymphatic-targeted drug delivery systems. So that's something to look out for. One of the things that I'm interested in using is these biological scaffolds. These are long tubular structures which can be inserted under the skin in the limb in a subcutaneous plane, and they're there to promote lymphangiogenesis. So that's something I'm quite looking forward to using and seeing what the outcomes would be. It is being used in Europe at the moment. So let's see what else comes through.
So as they say, watch this space, eh? Malia, that was really, really excellent. But I wonder if you might be able to give us a summary of the key points of this really important topic, please.
So first thing, history and examination, because it will dictate your whole treatment plan. Number 2 is your investigations, and that mainly is your dynamic and static investigation. So I would definitely mention a lymphoscintigraphy, definitely mention an MRI, and ICG lymphography for your dynamic lymphatic mapping. It's also crucial for surgical planning. Physiological procedures, LVA, vascularized lymph node transfer, work best in early moderate disease. Suction-assisted liposuction is effective for fat hypertrophy, but requires lifelong compression, and Charles procedure is the last resort for severe cases. Combining multiple techniques can improve outcomes. So those are the sort of summary points that I think if you can get them across, it should get you through.
Thank you so much, Malia. That was really, truly such a comprehensive and so very well structured podcast on the management of lymphedema. I'm sure our trainees in the UK, and indeed any surgeon anywhere in the world listening to this, would definitely gain a lot from it. Thank you so much.
Thank you for asking me. This is an amazing education platform, and I've really enjoyed the experience.
So there you go, guys. Management of lymphedema on Podplast UK.
Podplast UK is a collaboration between UK plastic surgery trainees and consultants. The content reflects individuals' practice, and opinions may vary. If you have any feedback, do get in touch. We hope that this has been interesting and useful. If it has, remember to follow us for future sessions.